Racial inequality in American healthcare. I'm Dr. David, and welcome to Your Health, Your Choice. Hello, it's good to see everybody again. We are going to be tackling a very challenging topic today, a little off the beaten path for this channel, but nonetheless something that I think is of incredible importance. Part of the goal of this channel is to help educate people, to really do things to help move the world forward. And the inequality in healthcare of our country has been a big thorn in this country's side for a long time, and is certainly having a significant impact on many communities in our country. Joining me today is Anastasia Wynn. Anastasia is a doctoral candidate in the Advanced Practice Leadership in Public Health program at University of South Florida, and she has a master's in the field as well. She is a health equity champion and is passionate about eliminating health disparities. Hi, Anastasia. Welcome to the show.
Hi, thanks for having me.
Yeah, so tell me a little bit first about this path that you've actually been taking, education-wise, career-wise, doctor level-wise. Tell a little bit of what got you here and the path that you had to take for that.
Yes, so originally I thought that I was going to be a medical doctor, and so the MCATs didn't work out too well for me, but I had a passion for public health. I was a public health major in college at Johns Hopkins University in Baltimore, and I fell in love with it. I took a health disparities course, and that's where I actually fell in love with public health and trying to eliminate health disparities and learning about health disparities. So that is what brought me here on this journey. I decided to get my master's and then go ahead and get my doctorate in public health. So I am now a candidate. I just am almost finished my doctoral project. I am working on my analyzing some qualitative data right now for that. So hopefully I'll be graduating in the summer.
That's great. And tell us a little bit in more detail about what your focus is in terms of what you're looking at.
Okay, perfect. So yeah, I'm focusing on the lack of participation of African Americans in clinical trials, specifically cancer clinical trials, because I'm interviewing research personnel at Moffitt Cancer Center. So I used to work at Moffitt Cancer Center as a clinical trials coordinator in the breast department. So we ran a bunch of different clinical trials there. And in the literature, you'll see, and then also at Moffitt, you'll see anywhere in the world, you'll see that there is less participation of African Americans on clinical trials. And so I was interested in that and understanding why, what are the barriers, and then trying to think of interventions to combat those barriers.
Why is it an issue that there's less representation in the African American community?
So if you don't have the representation in these clinical trials, then the results are less generalizable, right? So if you can't say that one drug works for a certain population if they're not in that clinical trial, right? And so all drugs have to be approved by the FDA. Everybody has to approve it in order for it to be on our shelves. And so if African Americans or Latinos or whatever the ethnic group is, if they're not participating in these clinical trials, then you can't say that these drugs are necessarily going to work for them. And it's also a problem because lack of access to novel care can be an issue as well. So if you have one group, if it's just all white males that are in these trials, then you can't say that that is going to work for a Black woman or Hispanic woman or even a white woman if you are only testing the drug on one specific population.
Yeah. And I could see how that could be a problem.
Yes.
Of course, I teed that up for you. But yeah, I think it's an important thing for people to understand that, you know, within ethnicities, within cultures. Genetics obviously plays a big part of it. Even like from some early understandings that I learned back in my nutritional work about like why Asian populations and why is it that African American populations are more prone to lactose intolerance, as an example. So if one was doing a study on how people tolerate milk, and all you have is white people in there,
Right.
then we may get a very not accurate view of what the impact of milk would be on people, just as a very basic understanding. But certainly, the type of thing that would make sense to kind of lead into further understandings of more complex things related to health, wellness, and treatments.
Right.
Now, before we go a little further, share a little bit about how we came into each other's lives.
Yes. So you are my daughter's pediatrician. She's 21 months today. And when she was an infant, a newborn, we were looking for a physician that would take her without having all of her vaccinations at that point, because my fiance and I were a little bit on different ends of the spectrum on whether or not to vaccinate her completely or do an alternative schedule. And so we were referred to you, and it's been a great experience so far. Ava loves you, and we love being patients of yours. So that is how we got to know each other.
Yeah, and I'm so glad that we did, and I adore your family, and
Appreciate
please
it.
tell them I say hi. Excellent. Well, that's good. Now, let's get on with some of the things. So, tell me about some of the implicit biases and the racial disparities that are prevalent in our society.
Yeah. So that's a complex question because implicit bias, there's so much like a negative connotation with it, right? But everybody has implicit biases.
Define it in your words.
Right. So if we are, if I have a certain, oh, you're putting me on the spot right now.
You did, right?
If I have a preconceived notion or thought about somebody coming in, say I'm a healthcare provider, and I have a preconceived notion about that person, I'm bringing that bias in when I'm talking to that patient, right? So if I take it in my realm of work, if I'm a physician and I'm running clinical trials and I don't offer a clinical trials to this African American patient because I don't think that they will be compliant with the drug or with the procedures or anything, that is an implicit bias, right? So that is like on a bigger scale of implicit bias, but we all have our different biases. So we just have to recognize that that we all bring those to the table, and so we have to be aware of those. So that's the implicit bias part. And then you asked me one other question about it.
Well, about racial disparities, but actually, and to kind of make a broader comment about that, even if let's say a white man were to come into a doctor's office, and that white man was maybe wearing a tie and a button-down shirt, and the next person who comes into the room maybe has some like cut off shorts or some cut up pants, and maybe looks like they hadn't bathed in a while or tattooed, etc. So it's also understood that implicit bias is not just related to race. Right. Obviously, that's what this conversation's about. But that would be an implicit bias in terms to how how those two individuals may be treated within the healthcare system, just based upon their appearance. For all we know, the person who with the cutoff with the cutoff shorts and with the tie dye may have just got off a Grateful Dead tour, and they themselves could be a PhD or a physician, and
right.
I may have been in that position myself once or twice, for that matter, too. I even went to a medical interview for the first job, and I got the job, where actually pretty much I had been overnight camping at a musical festival, and I was over the other side of the state, and that was the only time I would be able to meet with him, and he was actually cool with it, and I still got the job, so maybe that bias wasn't against me, but he was also a pretty cool guy out there. But yeah, so that is certainly the type of thing that just whether it's appearances, accents, all can make a difference in how the person on the other side of the desk may be perceiving that person. It's very sad, but it's also something that's just there.
Yeah.
Now, racial disparities. Tell me a little bit about some of the racial disparities, how they're manifested in the healthcare system, in
Yeah.
healthcare overall.
Yeah, so African Americans have they're disproportionately affected by almost every single medical condition you can think of, like hypertension, cancer, things like that. And it's not all genetic. It's not just because of genetics. It has a lot to do with your environment, socioeconomic factors. So things like that, like education, access to care, even if you have access, if you're actually going to the doctor. So all of those things play a role in health disparities. And so my passion is trying to identify those factors and work to think of interventions to eliminate or reduce those disparities.
Yeah. And even in terms of things that I kind of had come up with in a quick list that I had put together, shorter life expectancy. It's sad to say that the color of one's skin could actually make a difference in what the average life expectancy, and so we know that it's there.
Yeah.
Poorer outcomes overall. If the access to medical care is not the same across the board, later diagnoses, whether it's because of lack of access to healthcare in the first place, the implicit bias of the types of treatment and the treatments that may be offered in the first place,
Exactly.
the asking to be enrolled in the clinical trials, as I know that you've been involved in, and just how patients are treated.
Exactly.
And again, it's also sad to think and to know that those types of things exist, but yet they do.
Yes, and it's just very important, and I appreciate that you're bringing light to the fact that these things do exist.
Yeah, they do. Now, I know one of the things that we talked about before was how this is existing on different levels, both the systemic level, the provider level, the patient level. So, tell me, how you describe on the full system level, how is this manifesting?
Okay, so on the system level, you have the system or the organization, right? So if I'm a health institute, I'm a hospital, right? You have the providers and you have the patient. So all of that fall into the organization. So when we talk about like the social ecological model is the academic word for it, right? If you talk about this model, it's like they're all nested within each other. So it's not like just the individual level, just the patient level, just the doctor level, right? They're all nested together and they all affect one another. And so if you're thinking about the system level, you think about their policies and are they accepting certain insurance that Black people predominantly have, or people in that area predominantly have, right? That's one thing. What's their culture like within that system? Is it do they hire people of color? Is their leadership reflective of the patients that they serve? So all of those types of things would be at the system level, the organization level.
Okay, and how would you describe it at the provider level?
The provider level is again that implicit bias that can be brought to the table, and then the provider level and there's another level called the interpersonal level, and that's just the patient-provider communication, and so it plays a huge role in care. And when we talk about clinical trials, offering the clinical trial to the patient feeling comfortable with telling them their symptoms or things like that, or telling them why they can't participate in a trial or why they will have trouble getting to the facility, so transportation issues. So it all deals with like the trust between the patient and the provider that plays a huge role in quality healthcare.
Yeah. And, you know, because myself in our office, we're kind of on our own island here because we do have minimal interactions with most other professionals in the healthcare world. And, knowing how so many of those things are things that we addressed not even early on because that's kind of not what we brought to the table in terms of that, but just to kind of to not recognize the not just the individuality of people, but to just the respect for all people,
Mm-hmm.
to know that people are coming in the door for so many different reasons, and especially, obviously, it can speak mostly in the pediatric world, but everybody has one thing in common: they want their kid to do well.
Right.
Right. And so from our perspective, that's an easy thing to do, but obviously I realize that out in the real world that's not so happening. And even like in terms of like how much time a person can spend with a patient to understand a person's ethnicity, but also like their family background and
Right.
their family dynamics, which has such an important role. For me to check in with somebody of like, well, what is your support system that you have? Who
Exactly.
is there to help you with your healthcare? Who is there to help you with your child? What kind of things can I do to help facilitate that? Can I help educate other people in your family to come along to what we're trying to accomplish? And so, sometimes when I hear these things, that kind of like it's not foreign to me because I know that it's out there, but at the same time, just like, wow, that's still happening now.
I know.
Shouldn't we as a society pass that? But obviously, we know that it's not.
And that was going to be my
You know,
next point, which I love about your practice is that we can come in, we can ask the questions, and you don't make us feel guilty about asking those questions. There's no dumb question, and you take the time to explain things. And from my personal research and what is out in the literature, that is a big problem. And why patients don't participate in clinical trials or why they don't go to the doctors because they don't have that relationship with their doctor. And then we can't blame all doctors too because they're pressured to see a bunch of patients. And so when they have to see a bunch of patients, they don't get that time to spend with them to actually explain everything to them. And then when you're talking about clinical trials, they're so complicated. Like you have to sit down and break it down to anybody, right? And so when you don't have that time, it's really hard, and it's really hard to get that. To gain that trust and have that rapport with your patient. So one of the biggest things that I've seen as a barrier to clinical trial participation or just healthcare in general is that lack of trust between the patient and the provider. And so finding ways to help that patient provider relationship is one of the big things at the provider
mm,
level and also organization level.
yeah, yeah, and again, it's so distressing to know that those types of things are happening out there. But obviously, our types of conversations that we're having here, the type of research that you're doing at the university level, everything that we can do makes a difference. And
Right.
I'm really glad that we're having this important conversation now. Medical distrust, okay, especially among minority populations. Certainly for everything that's gone on in COVID right now, or the past 2 years, with so many conflicting pieces of information, recommendations, guidelines, you know, as a whole, it does seem as if society's trust in medical authority, government health systems, etc., seems kind of like almost at an all-time low across the
Across the
board
board.
right now
Yeah.
because there's so much confusion and the information that's out relative to what people are seeing on the ground, etc. But this is obviously something even more so that is coming up in minority populations.
Yeah.
So talk a little bit about some of that, like where maybe some of that distrust comes from in the first place.
Yeah. So, I mean, obviously, you have the historical context. So, you have Tuskegee, the Tuskegee experiment, so there's
Yeah, and
misinformation.
share for people who don't know what that is, what that was about.
Right. So in Tuskegee, now don't quote me on the years, but and there was an experiment done by the U.S. Public Health Association, or I think that was the name, but it was done in Tuskegee, and they withheld treatment for syphilis from these men, and I think women were involved as well. So there's a misconception that they gave people syphilis, right? And that's not true. They did withhold medicine after it was already approved for them. So that is one of the big things that people will refer to as why they don't trust the healthcare system, is because different things like that have happened, right? That's not the only example. You have examples of African Americans or slaves being used as to do experiments, to medical experiments. You have Henrietta Lacks, who in Baltimore, that was actually in Johns Hopkins. She had cervical cancer, I believe, and she did not give consent to be a part of research. But what happened was, when she died, they used her cells, and without her consent or her family's consent, and these cells became like huge, and they have been used to make vaccines, to make different all types of things. So those are just a few examples of historically why African Americans or minorities don't trust the healthcare system. But then you also have um, things like structural racism or things of that nature, where it's everyday experiences make it hard to go to the doctor, or like if I don't trust the doctor, I'm not going to go to the doctor, right? And so again, that big thing about trust that we keep talking about, it plays a huge role, especially in someone who already has that, who's already skeptical of um, the healthcare system. So mistrust and distrust, it's multi-layered, it's multifaceted. So you have it at the system level, again, the patient level and the provider level. You even have it. So one of the barriers at Moffitt for that came up is that Black people don't see Moffitt as a healthcare system for them, right? And that's come up in a couple of different interviews that I've done. And so why is that? Why don't Black people feel like they can go to Moffitt, right? So Moffitt as an institution has to figure out at the systems level, what can they do to be more trustworthy in the community, right? How can we go out and talk to local physicians? How can we talk to the community at the church level, or just be involved? And I know one of the big things is having people that look like you, like having people that look like the population you serve at the leadership level, at the physician level, when you walk through the doors, right? So that people do feel comfortable. It's all about being able to feel comfortable in the space, having that trust, and those are all different things that play into why Blacks and other minorities don't trust the healthcare system. On top of, like you said, the different the like for the COVID vaccine, everybody, no matter what race you were getting different information about things, right? And so just understanding that this is an evolving thing, right? And that we're learning as we're going. And some people just think that the doctors and the people in leadership are just supposed to know what and stick with one thing, and science is evolving. And just so understanding the concept of public health and the healthcare system, I think it just all plays a big role in mistrust in the healthcare system.
Yeah, and even things on the making things happen. Underserved populations are more likely going to have challenge getting to a healthcare
Right.
facility in the first place. Transportation there, the ability to take off work in order
Exactly.
to in order to have an appointment meet, the ability to have childcare if you have to go to the doctor, but you're a stay at home or a single mom or dad,
Mm-hmm.
and being able to do that. So there are those barriers that obviously, and that's not just a racial thing, that is more
Right.
of a social economic thing, it does
Mm-hmm.
appear to be. But I know that we've even talked a little bit about how, even social economically aside, that people of color, whether people even in better off social economic classes, are not necessarily treated the same way
Exactly.
as people that, if they're not in a minority situation. And I know that there's been a lot of looking and research that has shown that as well. And again, that comes back also to a lot of the implicit bias as well.
Exactly. I was going to point that back to the implicit bias. I have a friend who is a neurosurgeon, right? Went to Harvard, went to Hopkins, went to Harvard, top of his class. And he struggled with this as a physician, where the patients would be like, okay, so can you go get the doctor for me? Where's the doctor? Like, I'm not talking to you, I want to talk to the doctor. And he's like, okay, well, I'm right here. So I mean, you have that is a perfect example of implicit bias. So you're absolutely right.
Yeah. And even at the provider level, so one of my friends who is a holistic pediatrician up in the northern part of the state, and this was a decorated veteran, major in the army, I believe it was, who then went on to medical school and residency. And when she was in her residency, and they were trying to divvy up responsibilities, and one of the senior physicians even said, when they were trying, referred to her and says, yeah, I think she's trainable, and said this right to her face and in front of a bunch of other people. And she was not comfortable to like say, what am I, a dog?
Right.
What, trainable. I'm a decorated veteran here. I've shown my leadership skills, and you're telling me that I'm trainable. I mean, like, it was not said in a oh, this seems like a person who's really going to be able to learn. She's so intelligent. I'm so happy to be able to train her.
Right.
It was in a rather disparaging way. And just, I can't even imagine, this was a doctor who was being spoken to that way. So it's not just based upon the social economic status of an individual that these issues can happen.
Exactly.
Now, let's kind of, as we start to wrap this up, talk a little bit about what can we do going forward to try to turn this ship around.
Yeah. So when I started my project, when I was looking at the literature, like the barriers, and we touched on a lot of the barriers, right? The barriers are well known. So at this point, okay, we know the barriers. What are we doing about it, right? And so there's less information about intervention, evidence-based interventions to address these barriers at the levels that we talked about, right? And so that was my the goal of my doctoral project, is to come up with some interventions that actually address these issues. And so things that I'm seeing from the data coming from my interviews is training the physicians and the providers, not only the physicians, but the nurses, the coordinators, anybody that is involved with a patient's healthcare. They should all be trained on, they should have the cultural competency training. They should have the implicit bias training. They should have, and these trainings just shouldn't be just a one time thing, right? It's an evolving thing. It should be on at the onboarding when you first come into the institution. It should be quarterly or whatever that's going to keep it in your mind to say, hey, I need to be aware that this exists. I need to be aware that I have my own biases and my patients have their own biases, and how can I be better at talking to my patients so that I'm trustworthy to them. And so that was one of the things that I'm working on, that I want to work on, is a training that involves a medical mistrust piece that addresses those things for healthcare providers, to say, hey, this exists, this is real, and this is what we can do to combat it. So that helps at the provider level, that helps at the interpersonal level. And those were where I was seeing that there are not that many evidence-based interventions for. At the individual level, there's a lot of interventions, right, to bring awareness, to increase knowledge that clinical trials exist. So there are a lot of different programs or interventions that address the individual level. But it's not fair to just put all the onus on the patient, right? As an institution, we have to be trustworthy. As providers, we have to be trustworthy, and so we have to do our part as well as the patients. You know, so yes, educating the patients is great, but then we have to make it so patients do have transportation to our facility if they want to participate in this clinical trial. We have to make sure we do accept their insurance if they want to participate in this clinical trial. We have to make sure our leadership reflects our patient population. We have to make sure we have clinical trials that are for the diseases that are affecting our patient population, right, in our catchment area. So we have to do those things at the organization level. Make sure that we're hiring physicians that reflect all minorities, all ethnic groups, so it's more inclusive. Making sure we touched on the insurance and those types of things. So those are all things that can be done to help combat these barriers. And there's a long list of barriers, so there's definitely a lot of work to be done with these interventions, and just to make sure that they're evidence based and they're actually working. So you have to test them out and try them in the clinical trial setting, or going out into the community. That was another thing. Not just when you want something, right? Not when you have a grant and you want to get people on your trial, but going out to the community, showing up, like, this is, I'm here, this is, I can learn from you guys, you can learn from me, being personable, right? So these are all things that come up in the literature and have come up in my interviews with people at Moffitt. So these are all things that can be done, interventions that can be in the works to help combat these barriers.
Yeah, and and obviously, it's another really important thing is, the community leadership getting their buy-in.
Yep.
The power of the church and the clergy, and having that pulpit to where to preach to the masses, as we say.
Exactly.
How incredibly important that is. The business leaders in the communities, the sports leaders in the communities, because the entertainers. I know that these are people that those in the community look up to. They're role models. They're people who they will have buy-in to. So also getting the people that are looked up to be an active part of this is an important thing, because I can walk into a community and I realize I'm a little different. I could probably win over any crowd. I realize that's kind of like one of the things I can do. But that's kind of like not just that. Most doctors can't do that. Let's face it. But at the same time, if I were to walk into a community with Derek Brooks, and the two of us were to sit there and talk together and talk to anybody in Tampa about how important that would be. Let's face it, there's going to be a lot more buy-in there if Derek Brooks is there by my side talking about these things and not just me. So that's also another thing that I've really pegged that is so important. And we do see that happening, but I think that we can utilize those community leaders more in order to drive things a little more.
You're absolutely right. And then bringing them in at the organization level, right? Or having the patients, having the leadership involved in helping create clinical trials, or from the inception of the protocol for the clinical trial.
Right, not just back-ending it in and trying recruiting that,
exactly.
But like from day one, when you're setting it up, what do and asking those leaders, what do you see as the barriers? We may not be seeing it because we're not seeing it through those eyes. We're not seeing it through those community eyes.
Exactly.
So it's very important from the beginning on, not just kind of like retrofitting.
Yeah,
that's never any good thing.
Exactly, having them involved in the whole process.
Absolutely. Well, thank you so much for your time. As I said, this was a really important topic that I think isn't heard enough out there in this world. And so, as we do on this channel, we try to educate people. Health, education, choice. That's our tagline here. And obviously, so much here because the choice of the community and what they're buying, the choice of the individual and what they're buying, that's incredibly important too. So thank you so much for spending some time with us today.
Thank you for having me, and thank you for shedding light on such an important topic.